Hey Future Nurse Keys, it's me Rap from rapsnursingnotes.com, and in 5 minutes or less, we're gonna talk about how chronic kidney disease happens, what you'd see, and how to manage it. But before we get started, make sure you like, subscribe, and hit that notification bell so that you won't miss a single video when they come out. So let's get started. Chronic kidney disease happens when kidney function progressively and irreversibly fails that eventually it would lead to end-stage renal disease or ESRD. It is determined by the estimated glomerular filtration rate that falls below 60 milliliters of fluid filtered per minute per 1.73 meters squared of body surface area, a condition that lasts 3 months or longer. It goes by stages, from stage 1 to ESRD at stage 5. And this is when the GFR falls below 15, that without treatment, the client would die in a relatively short amount of time. Now, the major leading causes of ESRD are hypertension and diabetes. In hypertension, the walls of the blood vessels are thickened, causing less oxygen being delivered to the kidneys, ensuring ischemic injury. In diabetes, the high levels of glucose in the blood causes a scarring process to the glomerulus, which affects how well the blood is being filtered. Other causes include glomerulonephritis, autoimmune disorders, infections, as well as nephrotoxic agents and acute kidney injury that fails to recover. So on to the clinical manifestations. In ESRD, fluid imbalances happen because the kidneys are not able to produce urine. So there will be oliguria, meaning less than 400 milliliters of urine output per day, or even anuria, with very little or none at all. This buildup of fluid in the body causes fluid volume overload, and it can worsen existing hypertension. So third spacing would happen and manifest in general impeding edema. And this could even lead to pulmonary edema and result in respiratory distress. The kidneys are also not able to filter out toxins and waste products of protein metabolism. So you would see increased serum creatinine levels. Azotemia, which is high levels of urea in the blood and is reflected in increased BUN levels. And this can manifest in alterations in mental status, as well as uremic frost, or tiny white urea crystal deposits in the skin, especially around the scalp. The kidneys are also not able to filter out excess electrolytes into the urine, so virtually all the electrolyte levels will be high. Especially worth noting is hyperkalemia, which can cause arrhythmia or even cardiac arrest. Except for calcium though. Hypocalcemia happens because the damaged kidneys are not able to produce activated vitamin D, and they are required to absorb calcium from the GI tract, and this in turn would increase the secretions of PTH from the parathyroid glands in an attempt to increase blood calcium levels. However, this causes renal osteodystrophy because PTH takes the calcium from the bones and transfers them into the blood, causing malformations in the bones. In addition to these manifestations, signs and symptoms of anemia also happen because the kidneys are not able to produce enough erythropoietin. It's a hormone that stimulates the bones to produce red blood cells. So you would see low hemoglobin levels, pallor, weakness, and fatigue. Alright, I just want to pause this video for a second, but if you find this content valuable in any way, shape, or form, I just want to remind you to please like and subscribe because this would help my channel so much. Thank you. Alright, let's get back to the video and learn. So how do you manage it? As previously stated, the client with ESRD would die without medical intervention. The only cure is a kidney transplant. But another way to manage it is by dialysis, and this is for life. And 3 types exist. Number 1, there is hemodialysis, which uses a vascular access in the machine to perform clearance and filtration of the blood. On average, every treatment takes about 3 to 4 hours each, 3 to 4 times a week in frequency. The vascular access created may take weeks or months to mature for use for hemodialysis. In hemodialysis, there is also more risk for disequilibrium syndrome, which are nausea, vomiting, muscle cramping, hypotension, and they can be dangerous. This happens because the correction of the fluid and electrolyte happens too fast. The second type of dialysis is peritoneal dialysis. This uses the peritoneal cavity and an abdominal catheter to correct fluid and electrolyte imbalances. This takes about 8 to 10 hours in repeated cycles in the day, and is ideal for ambulatory and those with busy lifestyles. However, there is a risk for hyperglycemia and peritonitis. And the third type of dialysis is continuous renal replacement therapy. It is slow and takes about 8 up to 24 hours each treatment. So this is preferred with critically ill and hemodynamically unstable clients. In addition to these interventions, as a nurse, you want to educate the client to follow a renal diet. For example, help pick out foods with low sources of sodium and potassium, and teach proper fluid intake such as less than a liter of fluids per day. You also want to monitor fluid status by watching for changes in weight, and monitor electrolyte levels to ensure that the client is receiving adequate and proper dialysis treatment, and also to monitor trends in hemoglobin. Alright, so that pretty much wraps it up, and if you made it all the way in the end, that means you are here to learn something and you are to become a future nurski. And if you have not already, please like, subscribe, and hit that notification bell. Also, please write in the comments what Med-Surg topics you would like to see in my next video. Thank you so much, keep watching and keep learning, and I'll see you next time. Goodbye.